A recent publication in the Royal College of Pathologists Bulletin showed there was much room for improvement in optimising blood culture pathways across the UK. This presentation is about experience in one hospital of optimising the pathway. Approximately 18 months ago, there was a presentation, one of the main talks at a national conference in Ireland, titled Blood Cultures, Bacterial Microbiologists, Who is the Smart Money On? While this title might appear slightly flippant, it raises an important question. Within the Republic of Ireland, they are ahead of the UK in terms of blood culture pathway, and I hope to return to this at the end of the presentation. But going back now to almost 30 years ago, there was a publication by Rick Holloman from St George's Hospital in London showing that approximately half the patients yielding significant positive blood cultures commenced initial or altered antibiotic treatment on the basis of laboratory results. This was at a time when antibiotic resistance was uncommon, and he stated at the end of the paper that whilst an antibiotic policy allows effective treatment of many patients, there remains a need for an early microbiological diagnosis. In the intervening years, things have moved on. Bacteria have become more resistant, and they promise more resistant in the future. There are now continuous monitoring machines which will flag a positive blood culture 24 hours a day, 365 days a year. To many, the mere presence of a high-tech machine within a laboratory may appear to be enough. However, when some laboratories started auditing the blood culture pathway, they found that all was not as well as it seemed. They approached the UK Standards Group for Microbiology Investigation, and this resulted in an updated B37 investigation of blood cultures. This came out with at least two important recommendations: that laboratories should audit the blood culture pathway, and secondly, this was the first standard for microbiology investigation which set time standards for the critical control points. This is an overview of the critical control points in blood culture processing, which are represented by the lime boxes. The pink arrow represents opportunities for making up or losing time, whilst the purple arrow is relatively fixed in time once the blood culture is loaded onto the analyzer. In some publications, the time to positivity is measured from the time of loading to the bottle flagging positive. From the patient perspective, the clock starts when the blood culture is collected, so time to positivity in this presentation is measured from time of blood culture collection through to the time the blood culture flags positive. The blood culture from collection has to go through a number of hoops before it can get placed on the blood culture analyzer. The sample needs to be collected and get to specimen reception, and it's not infrequently to hear that specimens are sat around from midday in the emergency department only to arrive in the laboratory the following morning. At Chesterfield Royal Hospital, which is a small hospital, we receive approximately 8,000 blood culture sets a year. Until recently, these were glass bottles and required a porter to collect every set from the ward and transport it to the laboratory. From specimen reception has to find its way to the microbiology laboratory, and again, audit may show that even during the daytime, it can take 4 to 6 hours in one laboratory to move less than 50 meters from the centralized specimen reception to placement on the microbiology machine. It must be remembered that centralized receptions are extremely busy. At Chesterfield Royal Hospital, for instance, a small laboratory, more than 1 million specimens go through the centralized reception, and this isn't an excuse, but it gives some feeling as to why there might be delays. Once in microbiology, it should be placed on a blood culture machine, and during routine hours, Any bottles which flag positive are removed. At night, the situation is different. Blood cultures find their way to specimen reception, and a national survey showed that there was roughly a 50-50 split between laboratories either leaving the blood cultures at room temperature or placement in a separate incubator. Any blood cultures flagging positive outside of routine hours remain on the blood culture machine, and it's not until the next day that the blood cultures received overnight get onto the analyzer and any positives are removed. What we decided to do at Chesterfield was to move the blood culture machine into the centralized reception in blood sciences. So during day, specimens come in, and within a very short space of time following receipt, they're actually placed on the analyzer. Any positives which flag positive, the microbiology staff go downstairs to collect the bottles and process the specimens up in microbiology. At night, the specimens come in and are loaded onto the analyzer. But what we looked at, and this will be presenting the data in the ensuing part of the presentation, is to see whether we could use blood science to do the initial processing of positive bottles and what effect this would have on patient management and timings. The remainder of the talk looks at the impact of optimizing the pathway on time to detection and to patient management. Data from 2 anonymous hospitals chosen at random is used as a comparison. This table compares the average time to positivity pre-move and post-move following placement of the blood culture analyze in blood sciences specimen reception. Pre-move, blood cultures used to be placed on receipt in an incubator located in the blood sciences reception 24 hours a day prior to collection by microbiology staff. At first sight, the results are disappointing, the time to detection increasing following placement of the blood culture analyzer in specimen reception. However, the data illustrates an important point. If the contaminants are removed, which are variable in number and often take a long time to become positive, then relocating the blood culture machine has shown to reduce the time to positivity for all significant isolates. As time to positivity varies between genera, we have chosen to use E. coli as a comparison between laboratories. This is because this is a common isolate and rarely a contaminant. There are a number of potential reasons as to why placement on the analyzer is better than in an incubator. This includes faster equilibration to temperature and agitation of the specimen in the analyzer's silos. The effect of delay on receipt on time to positivity is shown in this table by dividing specimens into those received within an hour and after an hour. As can be seen, although the differences in time from pre-move to post-move are fairly modest, are measured in a number of hours, for laboratories which operate a fixed time, for example a cut-off of 8 o'clock at night and when they process a blood culture, moving the time to positivity backwards by an hour or more may mean it is processed the same day rather than being left to the following day, in which case results will be available a day later. This slide shows time from collection to placement on the analyzer. An audit has shown that the time between receipt and placement on the analyzer is negligible, being less than 10 minutes. This is results for approximately 80 specimens, and some of the specimens took so long, 17, 18, some over 20 hours, that they cannot be represented on this graph. It was felt that one way to actually improve the times was to introduce plastic bottles. Plastic bottles were introduced as this allowed staff to place bottles in the air tube system. Prior to this, glass bottles had to be transported to the laboratory by calling a porter to take the sample to specimen reception. This graph shows there has been an improvement, as shown by the orange bars, since the introduction of plastic bottles. However, more than 12% of samples still take more than 2 hours to reach the laboratory. At 2 to 3 hours now, whereas before it was roughly 1 in 5 samples, it is now 1 in 20 samples that take longer. However, these figures are still unacceptable, and this will be discussed further at the end of the presentation. On the left-hand side of the chart are the time from collection to receipt for specimens at Chesterfield, showing that 94% are received within 3 hours of collection. The blue bars represent data from another district general hospital, which has a centralized laboratory providing microbiology services to another hospital which has no on-site laboratory. By the time they have received 86% of their specimens, 89% of specimens at Chesterfield Royal Hospital containing E. coli would have flagged positive. With blood cultures being loaded directly onto the blood culture analyzer in specimen reception, it is now possible to send out real-time 36-hour negative neonatal blood culture reports. As can be seen here, within 38 hours of collection, 100% of 36-hour negative blood culture reports have been received by the ward. The blue bars represent time from collection to flagging positive for approximately 60 consecutive E. coli bacteremias in a teaching hospital. There is little delay between collection and receipt in the laboratory centralized reception, but delays during the working day may be incurred between specimen reception and loading the analyzer in the microbiology department less than 50 meters away. These delays can be in excess of 4 hours. At night, specimens are left at room temperature until the following morning. The orange bars represent data for approximately 60 consecutive E. coli bacteremias at Chesterfield Royal Hospital. This is the same data as the previous slide, but now presented as cumulative percentage of time to detection in hours of positive E. coli blood cultures. The blue bars, as before, are the teaching hospital, and the orange bars represent Chesterfield Royal Hospital. 89% of E. coli bacteremias have flagged up by 14 hours at Chesterfield Royal Hospital, in comparison to, at the teaching hospital, 25 hours. This is the same graph as before, but we'll now add data from the DGH hospital as represented by the grey bars. This represents a month's worth of data looking at the time difference between a positive blood culture flagging positive and being removed from the analyzer. 88% of positive bottles are removed within an hour. The tail is thought to be due to those specimens which flag around 6 o'clock in the morning, when blood sciences are often busy, so specimens are left till 9 o'clock for microbiology to process. And also, there are positive blood cultures which, when a gram stain is seen, show no organisms, so they are reloaded on the analyzer, and the analyzer records this as a bottle not being removed. The average time from flagging positive to removal at Chesterfield is less than an hour. But for the purpose of data comparison, we're now going to shift the original time to detection by 1 hour to account for the average delay. So whereas 89% of specimens used to be removed at 14 hours, this is now stating 14 to 15 hours. And we'll now compare that to the teaching hospital. As can be seen here, 89% of blood cultures at Chesterfield Royal are removed within 15 hours of flagging positive, whereas the same time is 37 hours at the teaching hospital. The large squares at the bottom are just to make it easier to see the hours. This slide is fairly self-explanatory. It represents the time from collection of the blood culture to the first clinical interaction between microbiologist and clinician after it flags positive. By 24 hours, 86% of blood cultures have been phoned through to the clinician. At this stage, this is usually the gram stain, but by the time we're reaching here, often it is the complete blood culture being run through with the gram stain and the sensitivities and the identification of the organism. This is a comparison between Chesterfield and the teaching hospital in time from collection to issuing a report with full sensitivities and ID. The data points collected vary between the two hospitals. At the university hospital, shown in orange, the data point of sensitivities is determined by the time the sensitivities are entered onto the laboratory information system. At Chesterfield, shown in blue, because it is not possible to get this data from the laboratory information system, two data points were used: whether the ID and sensitivities were available at 24 hours or whether they were available at 36 hours. And so you can see at 24 hours, 48% of the blood cultures, E. coli, were complete, compared to 2% with a teaching hospital. By 36 hours, 88% of the Chesterfield Hospital results were available, and this took more than 60 hours to be available at the teaching hospital. So in summary, at 24 hours, 86% of the E. coli bacteremias will have been phoned through to a clinician, of which 48% will have been completed. The ID and the sensitivities and a change of antibiotics will have been accomplished. And this shows it in comparison to the teaching hospital. We are now going to look at time to positivity for other genera, and this shows hemolytic streptococci and strep pneumoniae. The earliest positive blood culture, which was just over at 6 hours, as one might expect, was from a neonate who is said to have high titer bacteremias. However, the one at 7 hours from an adult, and although these numbers are small, you can see here it was possible to detect 3 group A bacteremias in less than 10 hours. These are the same figures as before, but now enterococci have been added, and this shows that there's a second peak with the enterococci tending to flag positive later than other streptococci. The blue bars represent Staph aureus, the orange bars coagulase negative staphylococci. Where the blood culture pathway has been optimized, it is then possible to infer that staphylococci flagging positive in a blood culture in 10 hours or less, unless the blood culture has been taken through a line which may have a heavy inoculum due to the presence of a biofilm, that this is likely to be a Staph aureus. For blood cultures flagging later, unfortunately, because some Staph aureus flag late, it is impossible to distinguish purely on time alone as to whether this is a coagulase negative staph or a Staph aureus. In this example, a 79-year-old lady was admitted via EMU. She came in late in the evening, a known aortic aneurysm, had a blood culture taken around about 9:30 in this evening, which was placed on the blood culture machine at 10:15. Clinically, she was seen by the surgeons who thought this was likely to be a leaking aneurysm. The blood culture flagged positive at just gone 4:30 in the morning and was subcultured around about 5 o'clock. And at 9:15 in the morning, a gram stain, because nothing had grown yet, showed staphylococci in both bottles. This was rung through to the clinician seeing the patient, who happened to be a physician, who felt that this was unlikely to be a bleeding aneurysm. There was no evidence to confirm it was bleeding, but the lactate and other features suggested the patient was septic. Because the staphylococci had flagged positive so quickly, just over 8 hours, it was communicated to the clinician that this was thought highly likely to be a Staph aureus. So the patient had a repeat blood culture taken, was started on a glycopeptide plus carbapenem, a glycopeptide and carbapenem because the patient was pen allergic and one couldn't be completely sure this would be a Staph aureus. Later on that day, once the cultures had grown, it was confirmed as a Staph aureus. The carbapenem was stopped, and in fact this patient had aortic valve endocarditis with the repeat blood culture being positive. It's all very well speeding up the blood culture pathway, but did this have any effect on the management of the patients? Before going into the results, just want to talk a little bit about empirical treatment of gram-negative sepsis. This is data from the East Midlands, and hospitals, in terms of their empirical treatment, broadly fell into 2 groups: those giving coamoxiclav plus gentamicin, or those giving piperacillin tazobactam. The average sensitivity to coamoxiclav is about 57%. In our hospital, roughly a third of gram-negatives are resistant to coamoxiclav, but the addition of gentamicin takes the combination to about 95% coverage. For those hospitals using piperacillin tazobactam, the average overall sensitivity is 87%, which means that roughly between 1 in 7 and 1 in 8 positive blood cultures will not be covered. The figures for ciprofloxacin are shown because this is often used for people who are said to have a severe penicillin allergy, and nationally resistance is running at about 20%. For the individual patient with a penicillin allergy who may experience repeated course of ciprofloxacin, the individual resistance may be higher. At the bottom shows sensitivity to carbapenems, although ideally this would be the best drug to use. One knows that it's not possible to do this, as it will encourage resistance. So when setting empirical treatment for gram-negative sepsis, the question is, at what level do you set the bar? And this will vary. But the important thing is that it's never going to be 100%, and you expect a degree of failure. The positive blood cultures with significant pathogens were analysed prospectively using this proforma. In analysing the positive blood cultures, they were allocated into one of 3 groups. One, if the patient was on at least one effective antibiotic. Second group was the patient was either not on an antibiotic or not on a effective antibiotic. And thirdly, partial treatment. This is where somebody had a deep-seated focus, for example a Staph aureus endocarditis, and the patient was on coamoxiclav or tazocin, drugs with some activity against but Staph aureus, but would be regarded as insufficient to treat the focus. There are 106 positive cultures containing significant pathogens. A third of patients were not on an effective antibiotic. 6 patients were not on antibiotics at all. 10 patients where the incorrect clinical source was identified. Usually this is where the patient was thought to have a chest infection, when in fact the source was either the urinary tract or the bowel, so coamoxiclav or amoxicillin were given without gentamicin. 10 patients were on partial therapy. Predominantly these were deep-seated Staph aureus infections, but there were 2 cases of streptococcal endocarditis. 15 instances where the guideline was not followed, so the patient should have received gentamicin in most of these instances with another antibiotic. 53 cases of escalation of therapy, so almost half the patients had their treatment escalated, and a third of roughly a third of patients had it de-escalated. So the benefits are, as already spoken about, real-time 36-hour negative blood cultures, improved management of patients, earlier de-escalation of antibiotics, reduced work on contaminants. So for example, if a staphylococcus, a bottle of positive blood culture flags positive containing a staphylococcus in the early hours of the morning, and it's grown by 9 o'clock, a quick latex will confirm that there's likely to be a coagulase negative staph, so it doesn't need to be phoned. The real-time results, as already shown, give clues to the relevance of organisms, particularly the gram-positives, and all the benefits were achieved through better use of existing resources. Now, in terms of analysing the patients who went on adequate treatment, so those not on one effective antibiotic or those on partial treatment, it was possible to analyse as to whether the gram stain, the identification of the organism, or the sensitivities would have corrected therapy. So of those not on one effective antibiotic, the gram stain was the most important in terms of correcting treatment. The ID was important in only 3 cases, for instance, unsuspected fungal infection, and there were 5 instances where the organism was resistant to coamoxiclav and gentamicin or cipro and gentamicin. For the partially treated infections, which were predominantly gram-positive, the ID would have actually made the difference. Knowing this was a Staph aureus or a streptococcus would have altered treatment, and only the sensitivities in one instance. The next step in this project is to look at providing a true 24-hour service. At present, blood science staff do not perform a gram stain. As shown in the previous slides, a gram stain would correct a lot of the inappropriate initial antibiotic therapy. And if one could have an ID as well as a gram stain, that would be even better. We don't think it appropriate to expect blood science staff to be able to perform a gram stain, and it's well known that experienced microbiologists can make mistakes. There are now platforms available which will perform the equivalent of a high-tech gram and even better. They will identify the organism as well as giving some antibiotic resistances. So the next stage is that when the blood culture flags positive, they will perform a test on these machines which will give an idea of the organism. This will then be rung through to the clinicians at night, who will use algorithms to manage the patients. A consultant microbiologist will be available in difficulties, but it's hoped that the algorithms will actually allow the patients to be managed without having to call the microbiologist. But if this is the way, the model of care for the future, manufacturers need to make the user interface friendly for blood science staff. At the moment, these machines are designed for microbiologists to use. I just want to mention briefly sensitivity testing. This diagram is from a French paper looking at the effect of having a laboratory operating 24 hours a day versus routine hours. This is the time to detection for an E. coli, which is an ESBL producer, has been reduced by 48 hours by having a 24-hour laboratory. However, it is now possible to actually improve upon this as there are rapid tests, and so the time to detection, if a rapid test had been used, could have been 65 hours earlier. This is a sensitivity plate which has been inoculated with 3 drops from a positive blood culture containing gram-negative rods. 4 discs have been added. These are ESBL detection discs, and also in the middle a gentamicin gradient has been applied. In the top right hand corner is the time in hours and minutes since the incubation was started. We will now watch a time-lapse sequence. One can see at 4 hours and 35 minutes this organism is resistant to gentamicin, the MIC appearing to be about 64, and that this is an ESBL producing organism, and those zoned to cefpodoxime, and a significant zone greater than 5 millimeters to cefpodoxime plus clavulanic acid. Now, if we go back to the earlier slides, and this shows the time to positivity for E. coli, with roughly 90% of E. coli blood cultures flagging up positive within 14 hours, 25% within 10 hours. Now, in recognizing a clinical response to antibiotic treatment, it takes at least 24 hours or longer in a lot of instances. Now, if one applies a rapid test, as you can see, this yellow line represents 6 hours. Most rapid tests are available between 4 and 5 hours. We are now getting to a point where we can test for resistance and actually predict antibiotic failure ahead of detecting this clinically. So, for instance, here, within 15 hours, 17 hours, or 19 hours of collection of the antibiotics, we will know that the organism is resistant to, for example, gentamicin or any SBL producer. This is an example of rapid sensitivity testing. An 84-year-old lady was admitted with sepsis, query biliary or urinary source. Initially started on coamoxiclav, but changed to tazocin as she was systemically so unwell. Blood cultures were collected at roughly HOPOS 1 on the 8th, and they were placed on the blood culture analyzer at 14:49. They flagged positive at 4 minutes past 3 in the early hours of the morning of the 9th, and they were subcultured at 03:20. At 9 o'clock the next morning, the routine sensitivity plates had not grown anything as it was too early, but this was seen on the rapid plate. So the organism, an E. coli, was resistant to gentamicin, rounding up to an MIC of 16 milligrams per litre. The patient was changed to meropenem. It was found, going through their previous microbiology, that they had previously had a gentamicin and tazocin resistant organism. And later on that day, 3 o'clock in the afternoon, the sensitivities had grown, which confirmed the E. coli was gent and tazocin resistant. Now, it might be argued that the clinicians should have looked through the previous microbiology and changed the antibiotics right at the beginning. Unfortunately, we know people make mistakes and these things do not happen. But equally, if this organism had been sensitive to gentamicin, it would have spared having to have used meropenem in this instance. If we go back to the slide at the beginning, bacterial microbiologists, who is a smart money on? Well, unless the blood culture pathway has been audited, no one knows how well it is functioning. Microbiologists have no idea. Clinical staff have no idea. They have a feel for the turnaround time of common tests such as full blood counts and use and ease, because on acute takes, they will expect results to be back in time for the next ward round. But it's not in their psyche to know what the turnaround time of a blood culture is, and most blood cultures anyway are negative. So if a patient's discharge is delayed because a result is not back, or a patient dies, it is not in their psyche to consider whether the blood culture result was delayed and that if it had been received promptly, it would have made a difference to the outcomes. However, it is in the psyche of the coroner, and following a number of high-profile deaths in Ireland, the coroner investigated these and found that microbiology was wanting because there were significant delays in the pathway. It was at this stage that the Irish National Accreditation Board, as we would call over here CPA or UCAS, looked for some standards. They didn't have any of their own, so they looked, as they commonly do, to the UK, and we do have blood culture standards, and they instituted them. The INAB gave labs a lead-in period of a few months, and if they had not achieved the recommended turnaround times, they would no longer be accredited for blood culture processing. But equally, on the ward level, a lot of staff do not appreciate that a blood culture is important. And this perhaps is because even within laboratories, we do not treat blood cultures with respect as we would an urgent specimen that we see, such as a CSF, with blood cultures being left lying around in labs overnight at room temperature. And talking to our clinical staff, they don't understand that it's important to get the specimen as quickly as possible to the laboratory. So we have developed some posters, this one highlighting the bottle may contain a killer, and the quicker you get the specimen to the laboratory, the more likely you are to actually prevent them from succeeding. This one perhaps is slightly more controversial, but it's correct. If blood cultures are left sitting around on a ward, it could mean a patient lying down forever. This toolkit is on the UK Sepsis Trust website, and it goes into a bit more detail than the SMI for blood cultures in terms of how one audits the pathway and what can be done to improve it. So in summary, blood cultures are collected from the sickest patients from an infection perspective within the hospital. But for the very sick patients, perhaps there's not much that microbiology can offer, because unless one has only one bite of the cherry, and if one does not get an appropriate antibiotic in within half an hour, there perhaps may not be another chance. However, blood cultures are taken from a much larger group of patients who have the potential to become the sickest in the hospital. There's significant inter- and intra-hospital variation in processing blood cultures across the UK. Audit is key to knowing performance, and substantial numbers of patients are not on effective antibiotic therapy. There's a feeling amongst some individuals that we give broad-spectrum antibiotics and patients are always on the correct antibiotic. But this is not the case. And one knows, without even auditing it, that this cannot be the case, because empirical antibiotic treatment and antibiotic guidelines has to accept a degree of failure. Optimizing the pathway will improve patient outcomes and allow rapid de-escalation of treatment, 36-hour negative results, early correction of treatment, reduced lengths of stay. It fits in with 7-day working, multidisciplinary working, and good antibiotic stewardship. Many of the improvements outlined can be achieved with better use of existing resources. There's not a cost to doing the basic things. The UK guidance has been adopted by Ireland and Scotland, but as yet, even though this is UK guidance, it is not enforced within the UK. All of this was made possible, and would like to thank the Blood Sciences Department at Chesterfield Royal Hospital for embracing this and helping us. Thank you.